Hi, everyone. Welcome to Fit for Fellowship, the survival guide for the General Cardiology Fellow. I'm Megan.
I'm Stacy.
And welcome. To those of you who are joining us for the first time, welcome. And then for those who are joining us for a second or third time or multiple times, welcome back.
As everyone probably knows by now, all of our sessions are recorded. And so you'll be able to access the videos either on the California ACC Fit website or on the California ACC YouTube channel. So definitely feel free to peruse these videos as many times as you need.
Fantastic. And we have a lot of great videos on the website, and we're going to dive straight into our next fantastic presentation. This will be given by Dr. David Donaldson of the University of California, Irvine. He is a electrophysiologist, and Dr. Donaldson earned his medical degree at the Sackler School of Medicine in New York State. He completed a residency in internal medicine and a fellowship in cardiology at North Shore Long Island Jewish Hospitals in New York, followed by a subspecialty fellowship in cardiac electrophysiology at Massachusetts General Hospital in Boston. He is a fantastic electrophysiologist whose interests include treatment of atrial fibrillation, atrial flutter, supraventricular tachycardia, VT, and PVCs with both medications as well as ablation therapy targeted treatments. So we're very excited to have him speak, and we look forward to his presentation, which we'll go into on atrial fibrillation.
Welcome to the California Chapter Virtual Fellows Bootcamp. I'd like to introduce myself. My name is David Donaldson, and I'm an electrophysiologist at the University of California, Irvine. And I have the pleasure of discussing with you management of atrial fibrillation. The topic of this conversation is going to be the top 3 clinical challenges for the incoming fellow. I have no disclosures. I'd like to first thank our organizers, which are going to be Scripps Health and the American College of Cardiology, the California chapter, and our project leaders for today are Dr. Megan Pelter and Dr. Stacy Tsai, who are currently fellows at Scripps Cardiovascular Institute in La Jolla, California. This is for incoming fellows as they start their fellowship, and this is to help them through this challenging time of transition from residency to fellows. We invite all incoming cardiology fellows here in California to engage in this project, and each lecture should address a certain topic, and we hope that it will be interactive, relatively short, between 30 and 45 minutes, and give opportunity for the fellows to meet in a collaborative state. The topics will be hopefully high yield, and we hope that this will help you with a steep learning curve so that you can appropriately engage yourself in your first call and have a successful fellowship. As I mentioned, each of these lectures should be 30 to 45 minutes in duration. There are going to be a total of 13 topics covered, and the first one today, which we'll discuss, is atrial fibrillation. So without further ado, we'll talk about management of atrial fibrillation, and these are the top 3 clinical challenges. The first one that we're going to talk about is case number 1, which is a brief clinical vignette, which is a 78-year-old male with a past medical history of hypertension, dyslipidemia. The patient has a history of esophageal carcinoma with known esophageal strictures. The patient has a history of coronary artery disease, has post-bypass surgery. The patient has heart failure, New York Heart Association class 2, and status B with non-insulin dependent diabetes. Because of his coronary artery disease, he's had PCCI to the LAD with Plavix, and that was in August 18th of 2018. And he presents to the emergency room where you're the fellow to assess the patient for sudden onset of palpitations. These palpitations started 3 hours prior to admission with the onset of feeling dizzy, lightheaded, but no chest pain or shortness of breath. Little in the way of additional past medical history, past surgical history, or allergies, and the social history is relatively non-contributory. The patient's medications at home include aspirin, 81 milligrams. The patient has Plavix, Zocor, 20 milligrams he takes at night with Lasix, 20 milligrams once daily, plus Corig, 3.125 twice daily, and Protonix, 40. Lisinopril, 5 milligrams, which he takes daily, in addition to metformin, insulin, and finasteride. When you assess the patient patient's relatively hemodynamically stable, 118/72 for his blood pressure. He's in a regular rhythm with a pulse of 112, a respiratory rate of 18. Oxygen saturations are 97% on 2 liters nasal cannula, and you find the patient to be well appearing. He's at stated age, pale, mildly diaphoretic, and his lungs have some bibasilar rales about 1/3 of the way up. His pulse, as I mentioned, is irregular. There are no rubs or gallops, and his abdomen is soft and untender. And truly speaking, he is otherwise looking well. No edema, alert and oriented ×3. And this is the EKG. The EKG is clearly atrial fibrillation. There are no discernible P waves here in lead 1, lead 2, or AVR. So this is consistent with atrial fibrillation with somewhat rapid, but more controlled heart rate. So clearly, this is atrial fibrillation. Atrial fibrillation is indeed the most common arrhythmia that you'll see in fellowship and in clinical practice. Essentially, it occurs in about 0.5 to 1% of the US population, and this is across all ages. Yet about 8 to 10% of the US population older than age 80 will have had either one episode of atrial fibrillation or are currently in AFib at that time. And essentially, we looked at some good data from JAMA in the early 2000s, which basically show that the incidence of and the prevalence of this condition is about 0.1% in a population less than 55 years old, but really jumps up to about 9% when you hit 85 or older. By definition, atrial fibrillation is 30 seconds of an irregular rhythm that is greater than 30 seconds. We sort of break it down into paroxysmal, persistent, and permanent. And for our purposes, paroxysmal terminates less than 7 days. Persistent is greater than 7 days, or the patient is required a cardioversion to get them back into sinus rhythm. And we can further break it down into what's called early persistent, which is basically less than 3 months, or long-standing persistent AFib, which is greater than 3 months, but yet not permanent. With the understanding that permanent is greater than 1 year, they've either failed cardioversion or cardioversion has never worked. So you as the fellow will have to think about initial management because you're evaluating the patient in the emergency room. And truly speaking, the initial management will start with a rate control strategy. And this is obviously with beta blockers or calcium channel blockers. And the next really important decision is, what do we do with stroke prevention strategies? Do we go with antiplatelet, anticoagulation? And then the big question is, do we need to cardiovert the patient? By that I mean, do we need to electrically or pharmacologically cardiovert the patient? We know that atrial fibrillation has ongoing embolic complication risk, and anticoagulation therapy is designed to specifically reduce the risk of systemic embolization. And we're really monitoring that versus the risk of bleeding complication. And as you all know, aspirin, Coumadin, dabigatran, rivaroxaban, apixaban, edoxaban, and others are our treatment strategies. One of the things that will come up is catheter ablation, and you're not thinking about that in the emergency room, but largely speaking, we do not try and offer catheter ablation to our patients to reduce the risk of stroke or TIA, but largely for symptoms. We know that the left atrial appendage accounts for between 90 and 95% of all thrombus that are associated with atrial fibrillation. And one of the newer strategies is exclusion of the left atrial appendage to mechanically prevent degeneration and or release of any emboli that start in the left atrial appendage, either with percutaneous left atrial exclusion procedures or a standalone cardiac procedure, or in conjunction with valve or bypass surgery. So let's go down the management strategies. Largely speaking, one of the things you're going to do once you stabilize the patient in the emergency room and you get heart rates under better control is you want to think about what the American College of Cardiology, the American Heart Association, the European Society of Cardiology have for guidelines. And there are continuously being updates, but I've selected this one because it's actually the most streamlined and I think the easiest one to remember. And largely speaking, you can break management of atrial fibrillation up into 4 main categories. So does your patient have no or minimal heart disease? Does the patient have heart failure or an established ejection fraction less than 35%? Does the patient have an established history of coronary artery disease, or do they carry a history of hypertension? In the patients who have no or minimal established coronary artery disease, this is your younger asymptomatic population with new onset atrial fibrillation. You truly do have a multitude of agents to use, including the class 1C antiarrhythmics, flecainide, then you have propafenone, and then you have sotalol, class 3 antiarrhythmic. That would be a first-line treatment in people with no or minimal heart disease. If that is unsuccessful, you can move on to amiodarone or dofetilide, two other class 3 antiarrhythmics, or move on to catheter ablation, with the understanding that these guidelines are currently being revamped and are updated. If the patient has established heart failure, ejection fraction less than 35%, that would be a group of patients with amiodarone or dofetilide would be your agents of choice, with the understanding that a 1C antiarrhythmic is contraindicated. If patients fail or break through those strategies, then catheter ablation is very reasonable. Now, what about your patient without heart failure? And they also have preserved ejection fraction, but they do have established coronary artery disease. That would be this third column. Now, unfortunately, these are a group of patients who dofetilide and sotalol would be our choices because 1C antiarrhythmics are contraindicated in this class of patients. We usually go with dofetilide or sotalol, and if that's unsuccessful, we could go down the realm of amiodarone or catheter ablation. Now, what about a patient with really no heart failure, no coronary artery disease, preserved ejection fraction, but they indeed do have hypertension? Well, this gets a little bit tricky because this is the grand majority of our patients that we're going to see. And usually the biggest cut point is, do they have substantial left ventricular hypertrophy? And the guidelines will be a little bit different in the hospital that you practice. But if we have patients who have significant left ventricular hypertrophy, then that's a group of patients where we would not be able to use the class 1C antiarrhythmics based on very established guidelines. So that would be a group of people who amiodarone would be our first line agent. And if that's unsuccessful, then catheter ablation with the understanding that they do not have left ventricular hypertrophy. Usually we have septal wall thickness, and in our lab about 12 millimeters or less. Then you could entertain the idea of flecainide, propafenone, or sotalol. If that's unsuccessful, then you can move on to dofetilide or catheter ablation. But what about in the emergency room? So your clinical decisions are based on signs and symptoms relative to the patient's heart rate, i.e., is the patient tachycardic and symptomatic in their atrial fibrillation? And this can be a whole host of things such as hypotension. Are they in congestive heart failure? Are they actually subjectively short of breath? Do they have worsening renal insufficiency, or are they actually in shock? Is there any decrease in their sensorium with decreased level of consciousness, angina, or are they having acute myocardial infarction? Well, that's when urgent treatment is necessary, and usually we move forward with immediate cardioversion, with synchronized cardioversion. Please don't be concerned too much with the amount of energy that you provide. Traditionally speaking, you can't be faulted with going with high energy biphasic cardioversion to minimize the likelihood that you wouldn't be able to get them out, with the understanding that body habitus, lung disease can increase the need for higher energy. Obviously, you'd want to pre-medicate with sedative medications, midazolam, barbiturates, etomidate, or ketamine with the assistance of your anesthesia colleagues, and then analgesia is essential with phetamine, morphine, or meteridine. Who do you not want to cardiovert? Well, if a patient actually is not in atrial fibrillation, but they're in a junctional tachycardia, you would not want to cardiovert because that's more of a compensatory mechanism. You want to treat the underlying cause. And the same with digoxin. Digoxin toxicity is a commonly found condition, and that's not a condition that we would actually want to cardiovert. And the same with atrial tachycardias. These tend to not convert all that well. They tend to recur very rapidly. So cardioversion for those patients with atrial tachycardia is not indicated. What about urgent treatment of the heart failure? This is a very commonly scenario that you're going to get called to evaluate because a patient's there with heart failure and they're in rapid atrial fibrillation. Well, now you have two competing forces because in patients who have a history of heart failure with preserved ejection fraction, or even for our purposes, let's say they have moderately reduced ejection fraction. If these patients have mild signs of congestive heart failure or they're hypotensive, you could cautiously consider attempting to rate control them with IV beta blockers or calcium channel blockers, with the understanding that calcium channel blockers are relatively contraindicated in patients who have reduced ejection fraction. One of the first things that you would want to do, however, is prioritize their heart failure status before you give IV beta blockers. In many of these people, we don't know the chronicity of their atrial fibrillation, and the atrial fibrillation is actually a compensatory mechanism because they're in respiratory compromise because of their congestive heart failure. So we would obviously stabilize their heart failure status before we give IV beta blockers or calcium channel blockers in an acutely decompensated heart failure. Please try and avoid the non-dihydropyridine calcium channel blockers in acutely decompensated heart failure because of the obvious negative inotropic effects. In addition to this, beta blockers may actually worsen the situation. They too have some negative inotropic effects. So the rule of thumb is treat the heart failure first. Now, what about your patients with a history of heart failure with reduced ejection fraction? IV digoxin and amiodarone for rate control is a reasonable choice, with the understanding that amiodarone does indeed have some mild negative inotropic effects, but it seems to be much more effective than digoxin. Once again, treatment of the heart failure with drugs, slowing the atrial fibrillation response is usually successful after you improve their clinical status. Uncommonly, do you have to cardiovert the patients into sinus rhythm? However, it is our last line of defense when patients are acutely decompensated and they're just not tolerating it well. With the understanding that if you cardiovert a patient in atrial fibrillation and they're still acutely decompensated in heart failure, this is a group of people that you're likely to have resumption of atrial fibrillation. We refer to this as early resumption of atrial fibrillation, or ERAF. When these patients have ERAF, it's likely due to not treating their heart failure appropriately. In patients who you're unclear of the duration, transesophageal echocardiogram should be considered. However, from a respiratory standpoint, that could be a conflicting interest. And the most important thing is to reduce the risk of an embolic complication with clear delineation of anticoagulation prior to cardioversion. So when should we shock? Well, if they're hemodynamically unstable, if they're in cardiogenic shock, if they're persistently tachycardic despite optimization of diuretic therapy, despite optimization of guideline-directed medical therapy, or if the patient has ischemia. In general, we prefer a rhythm control strategy for several reasons. This is because hemodynamic response improves the sustainability and substantially improves outcomes. And we really want to optimize ventricular function, and we know that sinus rhythm does a much better job of that. It's also associated with a dramatic improvement in heart failure. This is based on several large studies, including the AFCHF trial, very large trial. I put the data here, which basically was 1,376 patients with a reduced ejection fraction and rate control versus amiodarone, sotalol, and dofetilide, so the antiarrhythmic of choice. And basically at 37 months follow-up, there was really no significant difference in the primary outcome of death, cardiovascular causes between rhythm and rate control groups. And there was no significant difference in the outcomes of event-free survival. But there were improvements in quality of life, functional capacity, and the 6-minute walk. So rhythm control and catheter ablation can be very beneficial based on some recent large trials. There are 4 small trials that basically looked with some limitations that compared catheter ablation and rate control, and there was some benefit found. So for us, we stabilize the patient in the emergency room. We try and control their heart failure, get their rates under better control, and then you could think about what to do with their medications. So in patients with reduced ejection fraction, that includes dofetilide, sotalol if their ejection fraction is greater than 30% based on the SWORD trial, and amiodarone when we're very mindful of side effects. Let's talk about a second case, which is management of atrial fibrillation, case number 2. This is something that most likely you will see fairly early on in your fellowship. This patient happens to be a 63-year-old female. She has a history of a severely dilated non-ischemic cardiomyopathy, and she had a primary prevention dual chamber ICD inserted in outside hospital, and that was on June 13th of 17. And she never actually received any device therapy. Her heart failure status, class 2 and 3, functional status is C. She's got moderate to severely enlarged left atrium, and she's got moderate mitral valve regurgitation. And she presents to the emergency room. After recent urinary tract infection, she received levofloxacin, good clinical response, but had the sudden onset of lightheadedness, dizziness, palpitations, and unfortunately, she received an ICD shock. Past medical history and social history is stated above. No established allergies or medications from. She was actually on guideline-directed medical therapy. She was on Coreg 12.5 twice daily. She was on Entresto, Lasix, little potassium supplementation, and spironolactone. When you evaluated her serum, she was actually hemodynamically stable, 122/88. Pulse was now 60 and absolutely regular. She was well-stated female, no obvious distress at all. She was a little bit anxious, but heart was regular rate and rhythm, ICD site was clean, dry, intact, and she was not in heart failure. Here's her device interrogation. Well, Interestingly, the device did record several episodes. And essentially, if we look quickly at this first screen, the device has 12 years left on the battery. The last time the device had charged was actually on the 21st of March of 2021. All the numbers actually of her dual chamber device look nice and stable, thresholds look nice and stable, impedance look very good. So you're starting to gather some information. Why? Because if the patient received a shock, you want to make sure that the device is working appropriately. And we look at the thresholds, we look at the impedance, and everything looks fairly stable. So nothing that really jumps out at you. The other thing that you want to do now is to say, well, listen, how's this device programmed? And when I say programmed, there are Pachy and Brady settings. The way in which this device displays its information is that the Ddavp would start to detect at 250 beats per minute. The first therapy would be anti-tachycardic pacing, or what we say is ATP. And then the device would deliver multiple rounds of 41 joule shocks. That is for ventricular fibrillation. And the next is ventricular tachycardia. This would start to detect at 205 beats per minute. And the therapies would be burst pacing, which is a type of ATP. It would give several rounds of burst pacing. If that was unsuccessful, the device would indeed shock the patient. And for slower ventricular tachycardia, or what this device calls VT number 1, it would start at 185 beats per minute, followed by burst pacing and then a shock. The Brady settings are basically that it is set up in a DDDR mode, and the rates are 60 to 120 beats per minute. So now we know how the device is programmed. Let's pull up the episode in question. So the first thing we do is we pull up the electrogram of the event. The way in which this device displays the information is that this top line is actually what the atrial lead sees. The bottom line is what the right ventricular lead sees. And then this third line is what the coil, which is essentially part of the right ventricular lead. And this is a device which is actually the way in which the ICD is able to shock the heart. The device can actually measure the coil, and because it's a much larger structure, it gives us a much more large electrogram. And in that scenario, can monitor the device. So the first thing that the device sees is that in the atrial lead, you see a fast and irregular heartbeat. There is some regularity to it, but indeed the ventricle is a little bit slower, but indeed is very much irregular. This tells you what the device thinks it sees. So a sense means that it's actually sensing something going on in the atrium. And each of these numbers are the numbers in milliseconds between the spacing of each recorded atrial sensed episode. The markers on the second channel are what the device sees in the ventricle. So this is a ventricular sensed episode, which is this beat here, ventricular sensed episode here. And if it meets certain criteria, such as we talked about previously, based in milliseconds, it would determine whether it falls into ventricular tachycardia. So that was the second zone, or VT1, that was the first zone. And in this device, it also can look and see whether or not it matches an electrogram when the patient's in sinus rhythm. So this episode continues, where the device is monitoring a fast, irregular heartbeat. This is continuous recording here from a strip of the same episode, and it certainly increases in its rate, and the device starts to monitor and put it into various different bins. And the first bin, it fills, it completes that fill and talks about the duration of that episode. It then falls into a detection zone and starts the algorithm for ventricular tachycardia. As we talked about before, it starts with anti-tachycardic pacing, or V pacing, which is seen through here. It does it for a fixed number of intervals, which is fully programmable, usually between 8 and 10 beats. After it ventricular paces, or it does its anti-tachycardic pacing, it will cease pacing and see if the tachycardia terminated. Once again, the patient remained in their atrial arrhythmia, and with rapid ventricular response, it continued to time out here. And ultimately, it does more rounds of antitachycardic pacing. After its final episode of ventricular tachycardic pacing, the patient's heart rate actually accelerates, and the device at this point completes its algorithm and determines that it should deliver a shock. It charges, which you can see down here, and delivers a 41 joule shock, which now is delivered here, followed by a ventricular sense beat here, a ventricular sense beat here, and here. Now an atrial sensed episode, ventricular sensed, a ventricular sensed episode here, and ultimately the patient gets back into sinus rhythm. How do we know it's sinus rhythm? We have an atrial sense beat here, a ventricular sense beat here, and this is what the ICD tells us. And then we have on the shock, which is the coil, which we mentioned, it gives us a little bit more morphology. So now we can do a side-by-side comparison because the patient is back in sinus rhythm here, and we can compare that with when the patient received a shock for tachycardia. Because our question to ourselves is, why did the patient receive a shock? Was it atrial fibrillation with rapid ventricular response that actually timed out and received a shock? Was it actually simultaneous ventricular tachycardia and atrial fibrillation? Or was it just ventricular tachycardia? So this is where our investigation work starts. Clearly, we see that this is a sinus beat here and here. So the question is, do these beats look like these beats? But much more importantly, do these beats on the ventricular channel and the shock coil look similar to these? And the sweep speed and the size of these is a little bit different, but you can see on this ventricular sensed episode, it starts positive, deeply negative, then positive, just like here, which goes positive, deeply negative, and positive. And if we look on that shock coil, this morphology is completely positive and completely positive. So when we do a side-by-side comparison, even though this is an irregular rapid rhythm, it certainly looks like atrial fibrillation with rapid ventricular response, and the patient received a shock. So you as the fellow would have to determine whether the shock was appropriate or inappropriate. And in this case, it was inappropriate because it was not ventricular tachycardia. We know it was not atrial fibrillation and ventricular tachycardia, what we call a dual tachycardia, because the ventricular response at this time, the morphology looks very similar to sinus rhythm, and also ventricular tachycardia tends to be relatively regular. So in this case, what intervention should we be thinking of, and what else should we be doing in immediacy? Well, largely speaking, patients who have an ICD, a wide complex tachycardia, or if they receive a shock from the device, tends to favor ventricular tachycardia just based on statistics. Patients who have wide complex tachycardia in an ICD should be treated as VT until proven otherwise. Now, when no ICD therapy has been delivered and the device cannot be immediately interrogated, let's say due to lack of equipment, personnel, or patient instability, the initial treatment should be managed as if the patient did not have an ICD, which means you would do all the things for wide complex tachycardia, whether you had an ICD in place or not. Now, patients who have recurrent wide complex tachycardia, the ICD may not provide definitive management if the device has reached the programmed maximum number of therapies. What does that mean? Well, that means that the device is actually timed out, or the device has a wide complex tachycardia which fell below the detection rate, so that the device would not recognize it and therefore not treat it. People who have wide complex tachycardia with persistent multiple ICD shocks, your differential diagnosis is that they're actually in VT storm, either due to ischemia, electrolyte abnormalities, that it's SVT with aberrant conduction, as in our patient. However, in people who have multiple ICD shocks but no tachycardia, then you have to be thinking about device malfunction. And this could be lead fracture, this could be dislodgement of the lead, and most importantly, to prevent unnecessary shocks which are not clinically indicated, placing the device in a monitor mode with the programmer. And if a programmer is not available or you do not know which device it is, you can place a magnet over the device. Let's move on to our last case. This is a 79-year-old male who has very little in the way of past medical history. He is known to have atrial fibrillation. He's taking oral anticoagulants, and he presents with mental status changes. He had a fall at home associated with head trauma. He was found by his neighbor in front of his apartment building laying on the sidewalk. Unfortunately, we have no past medical history other than what we know from his clinical presentation. We really don't know any of his social or family history, and unfortunately, we only know that he was taking a blood thinner, but we do not know which blood thinner. He's borderline hypotensive, 102/62. He's a little bit tachycardic at 110 beats per minute. His respiratory rate is somewhat slow at 9, and he's saturating 92% on 3 liters nasal cannula. You find the gentleman to be an elderly male. He's somewhat older than stated age, and he's a little bit confused. He has a very large, prominent right orbital hematoma with a scalp laceration. His respiratory thorax is otherwise cleared auscultation, and he's in an irregular rhythm. And the remainder of his physical examination, other than some contusions and bruises and his limited neurologic exam, is unrevealing. So how do we best assess patients for the need for stroke prevention? As I mentioned, people have atrial fibrillation. Between 90 and 95% of all embolic complications that are cardiac in origin come from emboli that initiate and are formed in the left atrial appendage. We know that the left atrial appendage is a very complex structure, multiple different shapes and sizes with really prominent ridges, which we refer to as pectinate muscles. And the left atrial appendage can be abnormal, either due to inflammation, fibrosis, abnormal contraction, all of which lead to this increased risk of thrombus formation. And obviously we address this with oral anticoagulants, surgical left atrial ligation or amputation, and percutaneous occlusion procedures. How do we assess someone's risk of having an embolic complication related to non-valvular atrial fibrillation? Well, all of us are very familiar with the CHA2DS2-VASc scoring. And this basically came up with a study of risk factors associated with embolic complications related to non-valvular atrial fibrillation. The CHA2DS2-VASc scoring system is fairly straightforward. It was an advancement of the original CHAD scoring system, which basically used congestive heart failure. And this is really important that we define our patients very specifically to calculate their score of having an embolic complication, with the understanding that congestive heart failure either has signs and symptoms of heart failure, or they do have objective evidence of a reduced ejection fraction, and that would give you 1 point. Hypertension is really critically important. They have to have a resting blood pressure greater than 140/90, or at least 2 occasions of elevated blood pressure, and or on current antihypertensive medications. That gives them 1 point. In the original CHAD scoring system, age greater than 75 gave you 1 point, and diabetes with fasting glucose greater than 125 milligrams per deciliter, or they were taking an oral hypoglycemic agent and or insulin. And stroke included strokes, TIAs, or systolic embolization. And that gave you 2 points, with the understanding that stroke is the highest risk predictor of a future stroke. This was updated and was included in the CHA2DS2-VASc scoring system. And this, by similar criteria, gave stroke or a TIA 2 points. Female gender garnered 1 point. They adjusted the age, 60 to 75 gave you 1 point, and age greater than 75, 2 points, and tacked on vascular disease, including myocardial infarction, peripheral vascular disease, or profound aortic plaquing, giving you 1 point, for a total of 9 points altogether. And the risk of the CHA2DS2-VASc scoring system really does a nice job of assessment of this risk, with the understanding that if your CHA2DS2-VASc score of 0, your risk of a systemic embolization is less than 1%. And things really dramatically jump up between the 0 and 1 and then 2. Then once you have a CHA2DS2-VASc score of 2 or more, we start at about 3.71% per year. And then as the score increases, the risk becomes dramatically increased. So really what we are most concerned about are patients who are 0 or 2 or more. It gets a little bit more challenging in a patient who has a CHA2DS2-VASc score of 1. And look at the dramatic increase when their CHA2DS2-VASc score of 5, all the way up to 15.26%. We balance this risk of an embolic complication with the risk of a bleeding complication, and we use the Hasbled scoring system. Once again, this was patients who had non-valve or atrial fibrillation. These were patients who basically went for an assessment with a scoring of 0 to 9, with the understanding that hypertension by very similar controlled guidelines, but this is uncontrolled blood pressure, gives you 1 point. People have abnormal renal or liver function, 1 point for each. This is between 1 and 2 points. If they have a history of stroke, bleeding tendencies, if they have a history of labile INR for our patients taking Coumadin, if they're elderly, and this is age 65 or greater, or if they concomitantly take drugs such as aspirin, non-steroidal anti-inflammatories, or if they abuse alcohol. So if we look at someone's Hasbled score of 0, basically this is our patient who would benefit the most because they have a low risk of a bleeding complication, yet they have an elevated risk of their CHA2DS2-VASc score. Their bleeds per 100 patient year is 1.13, but unfortunately it jumps up rather dramatically. The data stopped at 5 to 9, but at 4 it was 8.7 bleeds per 100 patient years. So direct oral anticoagulants can be a challenge because routine coagulation tests are generally not used to determine the degree of anticoagulation. So you offer them a medication, but it's sometimes difficult to know quite where they stand. But the way that the pharmacology works with these medications, these as compared to the novel or the non-vitamin K oral anticoagulants, directly inhibit specific enzyme pathways within the coagulation cascade, as opposed to warfarin, which actually reduces synthesis of factors 2, 7, 9, and 10. So direct inhibitors of the thrombin, including factor 2A and factor 10A, work by several different mechanisms, but some of them may be associated with bleeding. So these can be serious blood loss, which is in the major trials, significant blood loss requiring a transfusion, or bleeding into a critical space, such as intracranial or in a compartment that's difficult to compress, or if it required significant intervention. So major bleeding has significant risk of immediate morbidity regardless of the cause. So the questions you'll have to ask yourself when you're assessing this patient in the emergency room is, number 1, is the patient actively bleeding? Number 2 is, what agent is the patient actually receiving and when was the last dose taken? So for our patient in the emergency room, with limited contact with his healthcare provider, we have to start to try and do as much background research as we can because we want to know what the patient took and when was the last dose. We then further assess whether there's any evidence of renal or hepatic disease that might cause excessive anticoagulation effect, and is the patient taking concomitant antiplatelet medications? Well, if the patient's hemodynamically unstable, this is going to be much more challenging because then you would have to speculate that they're actually having massive blood loss. Imaging is going to be absolutely essential. You're going to work very closely with your emergency room staff. And obviously, if there's any signs of bleeding, which is coming into the gastrointestinal tract, endoscopy is going to be critically important. Now, the one nice thing is that they're given the relatively short half-lives of most of these direct oral anticoagulants, even short-term and sometimes unneeded interruption can result in bleeding complications versus the risk of an embolic complication. So they have a short half-life, which is great for their reduced risk of bleeding complications. But by that same token, the longer that you withhold the oral anticoagulant, the higher they are at risk of having an embolic complication. So let's talk about urgent treatment, because this is what we're going to have to be most concerned about. Well, as I mentioned, we're going to do assessment of the anticoagulation status and the last dose that the patient was taking. So we continue, or we consider anticoagulation to have fully resolved after a total of 5 half-lives. So what's the half-life of these medications? Well, dabigatran, it's somewhere between 12 to 17 hours. So 5 half-lives is going to be 3 days. For rivaroxaban, that's 5 to 9 hours. So 5 half-lives are going to be 1 to 2 days. as opposed to apixaban, which is between 8 and 15 hours, giving you a 5 half-lives of 1.5 to 3 days, and edoxaban, that's actually 6 to 11 hours. So that's 5 half-lives of 1.5 to 2 days. And this is really helpful for us because when we consider how long we would withhold it, it'll help us understand when the patient will actually be back to their full coagulation capabilities. There are several caveats to this, that people who have renal or hepatic impairment, may have a greater degree of duration of anticoagulation. And traditionally speaking, we don't use coagulation testing with PT, PTT, and INR because this does not reflect the anticoagulation status of a patient receiving the direct oral anticoagulants. You can sometimes check a thrombin clotting time, or a TT, in patients suspected of utilizing dabigatran. And additional testing, including factor 10A heparin levels, which is sometimes a useful guide for the presence of a factor 10A inhibitor, or you could actually even use a quantitative factor 10A inhibitor analysis. But traditionally speaking, rapid and continued hemodynamic assessment, ICU admission, central line access, and effective airway stabilization will be your #1 priority. We're obviously going to optimize their blood pH. We're going to check for electrolyte abnormalities, and we're going to be monitoring their calcium very closely. So what if it's deemed that the patient should have reversal? Well, reversal agents are available. Dabigatran has a reversal agent that's called Craxbind. Idarucizumab is an agent which is available and at most institutions. For the direct factor 10A inhibitors, that's Adrexanet. This is a recombinant inactive factor 10A, which actually acts as a decoy for rivaroxaban and apixaban. It was approved for FDA use in May of 2018, and it has some very convincing evidence that it is able to restore the inhibition levels prior to treatment with the two agents, rivaroxaban and apixaban. So the reduction in anti-factor 10A activity was about 92%. So there is, unfortunately, the side effect, as I mentioned, that the adverse events include thrombosis. Now, fortunately, it's about 10%. And this was seen between the immediate reversal and up to 30 days follow-up. You can use non-specific agents such as the prothrombin complex concentrates, or what we call PCCs. The problem with this is thrombosis is a potential risk because of the pro-hemostatic agent. And there are the 3-factor PCCs, which include a mixture of factor 2, 9, 10, and then there's one that actually has 4 factors, which includes 2, 9, 10, and factor 7. Unfortunately, there are no high-quality data support the use of these PCCs and DOAC-associated bleeding. So caution should be made, and obviously good involvement from your colleagues in hematology would be critical. Generally speaking, we try and avoid the use of the recombinant activated factor 7 to treat DOAC-associated bleeding. Plasma products, that includes fresh frozen plasma or cryoprecipitate, can be used to reverse the anticoagulant effects of the DOAC. However, once again, this is with very limited evidence. And there are limitations and the practical consideration that this is going to be a fair amount of volume, that this could be transmission of infection, and that a transfusion reaction could occur. What about Ddavp or Desmopressin? Well, that can be used and associated with impaired platelet function, but not specifically for patients who are just there with bleeding complications related to direct oral anticoagulants. Now, what if the patient just recently took their oral anticoagulant? Well, this is where actually, if you administer the patient with activated charcoal, and usually it's within 2 to 8 hours, depending on the agent. And unfortunately, the factor 10A inhibitors cannot be dialyzed. And this just has to do with the fact that it's so highly protein bound that you won't get much in the way of dissociation. Okay, well, that's a spin through 3 major topics, which are going to be clinically important for you. I hope you had a nice review. And once again, thank you so much for joining me today. And I hope you enjoy your fellowship, and I hope you found this helpful. And I look forward to seeing you at future events. Thank you as always, and have a wonderful day.
All right. Fantastic talk by Dr. Donaldson. We're very happy and grateful to have him with us and to have him give this excellent presentation. So now we'll be moving on to the Q&A portion of this session. Unfortunately, due to technical difficulties, there's no live Q&A session, but we are recording this. And we have sent the questions to Dr. Donaldson.
The American College of Cardiology, California chapter virtual fellows.
We are recording this and we have sent him the questions and he has, graciously responded and we're very grateful to that. So Stacy and I will go back and forth and read both the questions as well as Dr. Donaldson's answers as well. So let's delve straight on in. So the first question is, when do you consider converting to rhythm control from rate control in patients with heart failure with reduced ejection fraction? And Dr. Donaldson said, in general, with patients with heart failure and reduced ejection fraction, I spend a significant amount of effort to try and maintain rhythm control as the AV optimization is so critically important in these patients. If they have failed antiarrhythmics, especially if they have failed a class 3 antiarrhythmic, or they have had 2 to 3 attempts at catheter ablation, and we are unable to maintain sinus rhythm, at that point, they would be determined to be permanent atrial fibrillation and would then adopt a rate control strategy. Excellent question and excellent answer.
So the second question is, how can I tell the difference between AFib with aberrancy and VT ECG? That comes from the case that Dr. Donaldson had given about inappropriate shocks from the ICD. So the answer that from Dr. Donaldson, this can be a very challenging question. Traditionally, we will start with the baseline EKG to compare that EKG with the patient's current presenting EKG. We would then utilize this baseline EKG with the understanding that if the patient has a left bundle branch block or right bundle branch block, we will be able to use the criteria for these two interventricular conduction delays to assess, as opposed to VT, which would have a different morphology. I rely heavily on the well-established morphology criteria for VT to differentiate. Lastly, VT is much more regular than AFib with aberrancy conduction.
Wonderful. Moving on to question 3. Are beta blockers and calcium channel blockers okay to use in heart failure? Some places allow for usage in certain heart failure patients, but wanted to get Dr. Donaldson's thoughts on this. And Dr. Donaldson had written to back saying, as discussed in the lecture, I strongly avoid calcium channel blockers because of their negative ionotropic effects. My cutoff ejection fraction is 35 to 40%. If patients have heart failure with preserved or mildly reduced ejection fraction, calcium channel blockers can be safely entertained. However, as discussed, optimization of heart failure is critically important. As it relates to beta blockers, once again, it is important to optimize heart failure status, as IV beta blocker therapy can sometimes cause hemodynamic collapse when administered in the setting of acute decompensated heart failure.
So the next question, in a patient without heart failure and someone who feels AFib but has failed rate control, how many antiarrhythmics do you try before you send them to ablation? Dr. Donaldson's response, this is a very challenging and somewhat personal provider decision. I tend to offer catheter ablation early in younger, highly symptomatic patients. As opposed to elderly patients with more comorbid conditions, I tend to have a trial of antiarrhythmic therapy. However, after one failed attempt with antiarrhythmics, I tend to offer catheter ablation even in somewhat elderly and sicker patients.
Wonderful. So next question that was asked is, what are your thoughts on starting aspirin on a patient with a CHADS VAS score of 1? And Dr. Donaldson's reply is that this is certainly challenging. With excellent tolerance and ease of use, the direct oral anticoagulation in patients with a score of 1, I would lean towards offering them oral anticoagulants. Obviously, this is balanced by the risk of having a bleeding complication via their Hasblad score.
And for the very first question, in your opinion, do you find that left atrial appendage occlusion devices versus left atrial appendage clip, which is more effective? The response is, this is a very interesting question, as both options have their risks and benefits. The benefit of a left atrial occlusion device is that it is a non-surgical option with good clinical data to support its use. I tend not to offer patients as standalone procedures a left atrial appendage clip. However, I am very supportive of surgical teams performing this in addition to cardiothoracic surgical procedures as an additional surgical option. The data is somewhat mixed on the efficacy of these head-to-head.
Well, great. I think those are all. Go ahead.
No, I was just going to say, I think we answered those are all the questions.
Yes, all of the questions. Thank you again, Dr. Donaldson, for the presentation and for answering our questions. And then,
yeah, I would say, so, this concludes our session for today. And as everyone knows, join us every Wednesday. Next week, we have another speaker, Megan, if you want to.
Yes, we have Dr. Elizabeth Helt from Cedars-Sinai, who will be giving a presentation on pacemaker basics. So very exciting. Also, again, something very practical and something that we use very much so on our first night of call and all calls subsequently. So we look forward to hearing her and her talk.
We'll see everyone next week.
All right, see everybody. Bye.